Hi everyone, a blessed day to all. Praying that all of you are safe and doing well together with your families and loved ones. This presentation is a continuation of our topic on the care of patients with problems in immune system. Before we proceed to our topic, let me read to you first this disclaimer slide. Please note, no copyright infringement is intended, and I do not own or claim any images, designs, and any of the original information stated and used in this video. And this is used for educational purposes only. If any content owners would like to dispute this, I will not hesitate to immediately remove the said content. If you happen to find your art or images in the video, please let me know and I will be glad to credit you. Here is my email, aubrey.dairit@cjhc.edu.ph. Here is the outline of this presentation. First, we'll talk about allergic assessment that includes the physiologic overview, assessment and diagnostic evaluation, and we'll talk about allergic disorders such as anaphylaxis and allergic rhinitis. And lastly, we'll talk about rheumatic disorder. So our body or our human body is bombarded by a host of potential invaders, such as your allergens as well as microbial organisms that constantly threaten its defenses. After penetrating those defenses, these allergens and organisms, if allowed to continue unimpeded, disrupt the body's enzymes systems and destroy our tissues. To protect against these agents, our body is equipped with an elaborate defense system. So the epithelial cells that coat the skin and make up the lining of the respiratory, gastrointestinal, and genitourinary tracts provide our body the first line of defense against those microbial invaders. One of the most effective defense mechanisms is our body's capacity to equip itself rapidly with antibodies. So, namely, your specific protein antigens. So, the antibodies prepare the antigens so that the phagocytic cells of the blood and the tissues can dispose of them. However, although the system is normally protective, in some cases the body produces inappropriate or exaggerated responses to specific antigens, and the result is allergic or hypersensitivity disorders. So, again, these are the particular ways of our antibodies in reacting with antigens. First, it is by coating the antigen surfaces if they are particular substances. Then by neutralizing the antigens if there are toxins. And by precipitating the antigens out of the solution if they are dissolved. An allergic reaction is a manifestation of tissue injury resulting from interaction between an antigen and an antibody. Allergy is an inappropriate and often harmful response of the immune system to normally harmless substances we call allergens. Those are dust, weeds, pollen, and dander. Chemical mediators released in allergic reactions may produce symptoms that range from mild to life-threatening. In allergic reactions, our body encounters allergens that are types of antigens, usually proteins, that the body defenses recognize as foreign, and a series of events occur in an attempt to render the invaders harmless, to destroy them and remove them from the body. When the lymphocytes respond to antigens, antibodies, which are your protein substances that protect our body against the antigen, these antibodies are produced. Antibodies combined with antigens in a special way, which has been likened to keys fitting into a lock antigens. Okay, fit only certain antibodies or the locks. Hence, the term specificity refers to the specific reaction of an antibody to an antigen. There are many variations and complexities in these patterns. So the antibodies are formed by lymphocytes and plasma cells in response to an immunogenic stimulus, constitute a group of serum proteins called your immunoglobulins. These immunoglobulins are grouped into 5 classes that includes the IgG, IgA, IgM, IgD, and IgE. These immunoglobulins can be found in the lymph nodes, tonsils, appendix, and Peyer's patches of the intestinal tract or circulating in the body and the lymph. These antibodies are capable of binding with a wide variety of antigens. The immunoglobulins of the IgE are involved in allergic disorders and in some parasitic infections. The IgE-producing cells are located in the respiratory and the intestinal mucosa. 2 or more IgE bind together to an allergen and trigger the mast cells or basophils to release a chemical mediator such as your histamine, serotonin, kinase. Slowly reacting substances of anaphylaxis and the neutrophil factor also, which produce allergic skin reactions, asthma, and hay fever. So these are the roles of our cells. For B cells, or known as the B lymphocytes, they are programmed to produce one specific antibody. So upon encountering a specific antigen, B cells stimulate production of plasma cells, the site of antibody production. So the result is the outpouring of antibodies for the purpose of destroying and removing the antigen. Now the role of our T cells or our T lymphocytes, it assists the B cells, and then the T cells secrete substances that direct the flow of the cell activity, destroy the target or the target cells, and stimulate the macrophages. The macrophages present the antigen to the T cells and initiate the immune response. They also digest antigens and assist in removing cells and other debris. So, unlike a specific antibody, a T cell does not bind free antigens. These are the function of antigens. First is the complete protein antigen, such as animal dander, pollen, and horse serum. It stimulates humoral response, while the low molecular weight substances, such as medications, they function as haptens or incomplete antigens. They bind to tissue or serum proteins to produce a carrier complex that initiates an antibody response. During allergic reaction, the production of antibodies requires active communication between the cells. And when the allergen is absorbed through the respiratory tract, gastrointestinal tract, or skin, allergen sensitization occurs. Macrophages process the antigen and present it to the appropriate cells, and these cells mature into allergen-specific secreting plasma cells that synthesize and secrete antigen-specific antibodies. There are two types of medical mediators that includes primary mediators and the secondary mediators. The function of the chemical mediators mast cells, which are actually located in the skin and mucous membrane. It plays a major role in IgE-mediated immediate hypersensitivity. When mast cells are stimulated by antigen, powerful chemical mediators are released, causing a sequence of physiologic events that result in symptoms of immediate hypersensitivity. So again, there are two types. The primary mediators are preformed and are found in mast cells or basophils, while the secondary mediators are inactive precursors that are formed or released in response to primary mediators. So under your primary mediators, we have histamine, eosinophil chemotactic factor of anaphylaxis, platelet activating factor, and the prostaglandins. So the histamine is released by mast cells and it plays an important role in the immune response. It is actually the first chemical mediator to be released in the immune and inflammatory responses. It is sensitized and stored in high concentration in the body tissues exposed to environmental substances. So, histamine's effect peak between 5 to 10 minutes after antigen contact. And this includes the following. The patient may experience erythema or redness, localized edema in the form of wheals, there could be pruritus, and there will be contraction of bronchial smooth muscle. So, pwedeng magkaroon ng difficulty breathing ang pasyente, resulting in wheezing and bronchospasm. Dilation of small venules and constriction of the large vessels can also happen, and increased secretion of gastric and mucosal cells that results into diarrhea. Kaya sometimes, yung pasyente na may allergy nagkakaroon din ng diarrhea. So, diphenhydramine or the Benadryl is an example of an antihistamine. So, the second primary mediator is again the eosinophil chemotactic factor of anaphylaxis. So, this affects the movement of eosinophils or the granular leukocytes to the site of allergen. It is preformed in the mast cells and is released from disruptive mast cells. The third one is the platelet activating factor, which is responsible for initiating platelet aggregation and leukocyte infiltration at the sites of immediate hypersensitivity reactions. It can also cause vasodilation, bronchoconstriction, and increase vascular permeability. The fourth one is the prostaglandins. It is produced smooth muscle contraction as well as vasodilation, and it increases capillary permeability. They sensitize pain receptors and increase the pain associated with inflammation. So in addition, the prostaglandins induce inflammation and enhance the effects of mediators of the inflammatory responses. Local manifestations include erythema, heat, and edema. The secondary mediators include leukotrienes, bradykinin, and serotonin. Leukotrienes are chemical mediators that initiate the inflammatory response. Manifestations can be attributed in part of leukotrienes. There could be inflammation, and leukotrienes can also cause smooth muscle contraction, bronchial constriction, mucus secretion in the airways, and typical wheal and flare secretions of the skin. So compared with histamine, leukotrienes are 100 to 1,000 times more potent in causing bronchospasm. So, pwedeng magkaroon again ng difficulty breathing ng pasyente. Bradykinin is a substance that has the ability to cause increased vascular permeability. vasodilation, hypotension, and contraction of many types of smooth muscles of our body, such as the bronchi. It also increases permeability of the capillaries, resulting in edema. So it stimulates nerve cell fibers and it produces pain. Serotonin, on the other hand, acts as a potent vasoconstrictor and causes contraction of the bronchial smooth muscle. So please take note that although our body's immune system defends our body against the infections and foreign antigens, immune responses can themselves cause tissue injury and disease. Hypersensitivity reaction is an excessive or aberrant immune response to any type of stimulus. So it usually does not occur with the first exposure to an allergen, but the reaction can follow a re-exposure after sensitization or build-up of antibodies. So injuries or pathologic immune reactions are classed as hypersensitivity reactions, the first category of our immune disorders. That includes type 1, the anaphylactic reaction, type 2, or the cytotoxic reaction, type 3, or your immune complex reaction, and the type 4, delayed hypersensitivity reactions. The other category includes allergic disorders, autoimmune, and immune deficiency disorders that could be congenital or acquired. So now let's discuss each type of hypersensitivity reaction. The first one is the type 1, your anaphylaxis. The first type, or the type 1 hypersensitivity reaction, known as anaphylactic reactions or anaphylaxis, is the most severe type. An anticipated severe allergic reaction that is rapid in onset, or it is immediate response. Anaphylaxis is characterized by edema in many tissues, including the larynx, and is often accompanied by hypotension, bronchospasm, and cardiovascular collapse in severe case. So again, it involves an immediate reaction beginning with minutes of exposure to an antigen. So the primary mediators are responsible for the symptoms of the type 1 hypersensitivity because of their effects on the skin, the lungs, and gastrointestinal tract. If the chemical mediators continue to be released, a delayed reaction may occur and may last for up to 24 hours. Clinical symptoms are determined by the amount of the allergen, the amount of mediator release, and the sensitivity of the target organ, and the route of allergen entry. This may include both local and systemic anaphylaxis. So it's very important that as a nurse, you know how to assess your patient, because this can be cumulative, or this can be life-threatening. So this is a figure of our type 1 hypersensitivity reaction. So the triangles are the antigen, and the brown one, these are the IgE antibody, and these are the mast cells, and there is a release of vasoactive amines and other mediators. So again, your type 1 anaphylactic reaction is characterized by vasodilation, increased capillary permeability, smooth muscle contraction, and eosinophilia. Systemic reactions may involve laryngeal stridor, angioedema, hypotension, and bronchial problem, gastrointestinal problem, or uterine spasm. Local reactions are characterized by hives. Example of type 1 reactions include extrinsic asthma, allergic rhinitis, systemic anaphylaxis, and reactions to insect stings. So moving on to our etiology or pathophysiology of your type 1 hypersensitivity reactions. This involves the characteristic activations of our immunoglobulin or IgE bound to mast cells whereby histamine is then released. So again, the clinical manifestation of your hypersensitivity reaction includes bronchospasm, such as wheezing, rhinorrhea, urticaria, angioedema, and anaphylaxis. Maybe progress from local to systemic reactions. This is just an example image of urticaria, just for you to know what is urticaria. For the diagnostic and laboratory test findings for hypersensitivity reaction, we have immunoglobulin titers that are predictive of potential allergen response. And we also have skin and patch testing, which are performed to determine potential allergens. So as a nurse, you can instruct your patient as part of your health teaching to avoid taking immunosuppressive or corticosteroids prior to the test. And instruct your patient to avoid sunlight or sunburn at least a week before the test. Of course, para you can have inaccurate findings. And then you can apply the patch test that will take about half an hour. Allergens is round or square chamber are applied to the upper back. And you have to instruct the patient to keep it in place with special hypoallergenic adhesive tape and let it stay in place for about 48 hours. Also instruct your patient to avoid the back from getting wet. So, ibig sabihin, hindi siya pwedeng maligo muna, half bath lang. After 48 hours, patches are then removed. Results can be negative or irritant reaction. There will be sweat rash, weak positive, or there will be slightly elevated pink or red plaques. Or the result could be strong positive. There will be papulovesicles. And lastly, there could be extreme reaction kung saan nagkakaroon ng blister or ulcer formation. So these are the therapeutic management for hypersensitivity reaction. The first one, the patient may be given antihistamines such as your Benadryl. Mast cell degradation inhibitors such as cromolyn sodium, decongestants, corticosteroids, and epinephrines, particularly for severe reactions. The most severe type of your hypersensitivity reaction is the type 1, which is also known as anaphylaxis. Anaphylaxis is an acute, life-threatening allergic reaction marked by rapidly progressive urticaria and respiratory distress, which may lead to anaphylactic shock. So, pwede itong ikamatay ng pasyente kasi there will be narrowing of the airway. So, anaphylaxis results from ingesting or other systemic exposure to allergenic substances that includes drugs such as penicillin and other antibiotics, vaccines, hormones, and local anesthetics. So, therefore, as a nurse or as a student nurse, if you are giving medication to your patient, particularly antibiotics, and as mentioned, it is important that you must ask your patient kung meron ba silang allergy. Actually, kapag wala, pwede rin magkaroon ng skin test prior to drug administration. You also ask your patient if merong allergies of food such as nuts, seafood, egg albumin, and etc. Sulfite-containing food additives and insect venom, such as the honeybees, spiders, and etc. These all can cause anaphylaxis, so you have to be very careful. So the sign and symptoms of anaphylaxis includes local effects and systemic effects. For the local effects, there will be red flares, urticaria, yung pinakita kong picture kanina, usually not dangerous. But for systemic effect, it includes intense urticaria. So sobra na talagang namamaga na yung kaya nagkakaroon na ng edema on the site of injection or injury is spreading to the face, hands, and body areas. So another sign and symptoms of anaphylaxis includes respiratory distress, wherein the patient may experience bronchospasm, coughing, sneezing, and wheezing. Arrhythmias, tachycardia, or brady or hypotension, or there could be circulatory collapse. The patient may also suffer nausea and vomiting, abdominal pain, and diarrhea. The diagnostic procedure for anaphylaxis includes serum and urine histamine and serum tryptase. Tryptase are released from mast cells during activation. That's why it is also known as the mast cell enzyme marker. So the nursing intervention or your management for the patient with anaphylaxis. So it is important to establish airway. So you can administer epinephrine through IM or subcutaneous, of course, as ordered. Maintain a patent IV access for emergency drugs administration. You can also give oxygen, and of course, the doctor may perform tracheostomy. So therefore, you have to prepare tracheostomy set and assess the vital signs, the ECG, the ABG, and urine. You can also administer medications as ordered, such as antihistamines, bronchodilators, vasopressors, and corticosteroids. So part of your nursing intervention is to do health teaching. So you have to teach preventive measures. You instruct your patient to avoid or eliminate offending allergens. Huwag kakainin yung mga bawal. Carry anti-sting kits if allergic to insect bites. And the patient should have ID tags or bracelet just in case nagkaroon ng anaphylactic reaction ang pasyente. Maintain safety precaution. Always remain within 30 minutes after administration of new drug. That is for you to check if the patient has allergy to that particular drug. Always check for allergies before administration of drugs as ordered by the doctor, particularly for prescribed medication or over-the-counter medication. Now moving on to the second type of hypersensitivity reaction, which is also known as your cytotoxic reactions. The type 2 or cytotoxic hypersensitivity reaction occurs when the body or when the system mistakenly identifies a normal constituent of the body as a foreign. This reaction may be the result of cross-reacting antibody, possibly leading to cell and tissue damage. Type 2 hypersensitivity reactions are associated with several disorders. For example, in myasthenia gravis, the body mistakenly generates antibodies against the normal nerve endings. In good pasture syndrome, it generates antibodies against the lung and renal tissue. producing lung damage and kidney injury. So it involves the activation of complement and is considered a form of humoral immunity. Complement, these are circulatory plasma proteins which are made in the liver. These are activated when the antibody connects with an antigen. In destroying an invading organism, it is not enough for the antibody to attach to the antigen. Therefore, complement must be activated. It involves IgG and IgM. Okay, antibody bonds to an antigen that leads to eventual cell damage. Complement is activated, but unfortunately, the normal constituent of the body is mistakenly as foreign substance. So this is just a figure of what happens to our body during type 2 hypersensitivity reaction or a cytotoxic reaction, which again involves binding either the IgG or IgM antibody to a cell-bound antigen, may lead to eventual cell and tissue damage. The reaction is the result of, as mentioned a while ago, mistakenly identity. When the system identifies a normal constituent of the body as foreign and activates the complement cascade. Example, as mentioned a while ago, is the myasthenia gravis and Goodpasture syndrome. So the etiology and pathophysiology of type 2 hypersensitivity reaction involves the production of autoantibodies that cause the individual to destroy one's own cells or tissues. The IgA and IgM are involved in this type of hypersensitivity reaction, wherein the complement system is activated. The clinical manifestations include hemolytic reactions and target cells destruction. For hemolytic reactions, it includes transfusion, erythroblastosis fetalis, hemolytic anemia, and drug-induced hemolysis. For target cell destruction, there could be pulmonary and renal involvement. An example, myasthenia gravis and Goodpasture syndrome. The diagnostic and laboratory findings for type 2 cytotoxic and cytolytic reaction is Combs test that can define the presence of hemolytic anemia and also identify potential ABO incompatibility. So for therapeutic management, it is important to identify potential infectious sources and establish baseline immune level, and then collaborate with dietitian in order to support immune functions and maintain integrity of the body system. Also, it is important to properly identify the blood products during administration. For nursing intervention, as a nurse, it is important to remain in the room of your patient during the first 15 minutes of any blood product administration. Of course, this is for you to know if there is allergic reaction. Okay, and then it is important to follow hospital policy and procedure for the administration of any and all blood products. It is also important to have at least 2 registered nurses to verify the doctor's order. That is, you can also apply or use your 10 R's or 10 rights of administering medication that can be applied as well to administering blood products. And of course, it is important to check the cross-matching paper of your client. Now moving on to hypersensitivity reaction type 3, which is also known as immune complex reaction. So the type 3 or immune complex reaction, there is a formation of antigen-antibody complexes. This antigen-antibody complexes is not localized. That could result in more extensive tissue or organ destruction. Now let us look at what happened to the cell during type 3 hypersensitivity reaction. So this shows the antibody or antigen-antibody complex, and this is the complement. There would be infiltration of PMN or your type of white blood cells into the cell. Okay, there would be damage to adjacent cells. Okay, so again, type 3 is an immune complex reaction which is marked by acute inflammation resulting from formation and deposition of immune complexes. The joints and kidneys are particularly susceptible to this kind of reaction, which is also associated with systemic lupus erythematosus, serum sickness, nephritis, and rheumatoid arthritis. Some signs and symptoms include urticaria, joint pain, fever, rash, and adenopathy, or there would be a swollen glands. The clinical manifestation of type 3 hypersensitivity reaction includes arthus reactions that involves a localized inflammatory response with excess IgG, causing edema and necrotic lesions. Serum sickness involves a systemic response leading to the deposit and activation of complements throughout the body. That can be demonstrated as joint pain, pyrexia, and/or lymphadenopathy. Reactions can be acute or chronic in nature. So, the diagnostic and laboratory findings for type 3 hypersensitivity reaction includes complement assays that provide diagnostic and predictor indicators of the acute and/or chronic nature of the process. There could be ESR elevated and proteinuria. The therapeutic management for type 3 hypersensitivity reaction includes analgesics, antihistamines, and topical steroids. Of course, you can only give this as ordered by the physician. The nursing interventions for type 3 hypersensitivity reaction includes the following. As a nurse, you have to be attuned to the potential development of inflammatory localized reactions at the site of serum injections after 1 week. Can be followed by a more systemic response involving both regional as well as generalized lymphadenopathies. So, if the symptoms arise, it is important to monitor your client for potential complications if organ damage arises and the kidneys are compromised. Now, let's move on to the last type of our hypersensitivity reaction, the type 4 or delayed hypersensitivity reaction. The type 4 hypersensitivity reaction is a form of cell-mediated immunity involving the T lymphocytes. It is considered a delayed response because it can occur between 1 to 3 days after exposure to an antigen that causes the cell and the tissue damage. So, for the pathophysiology and etiology, there will be delayed hypersensitivity reactions involve the recognition and response of T lymphocytes to a foreign substances. So again, type 4 hypersensitivity reaction occurs between 1 to 3 days after exposure to an antigen. So the reaction, which results in tissue damage, involves activated by lymphokines, macrophages, and lysozymes. Erythema and itching are common. A few examples include contact dermatitis, graft versus host disease, Hashimoto's thyroiditis, and sarcoidosis. So the following are the clinical manifestations for type 4. Tuberculin response or poison ivy and graft dermatitis to transplant or graft rejection. The patient may also have edema, ischemia, and eventual tissue destructions may ensue. Also, the patient may experience pyrexia, pain, edema, and failure of the transplanted organ characterized transplant rejection. The diagnostic and laboratory findings for type 4 includes PPD testing resulting in induration of more than 5 mm, identified type 4 hypersensitivity to the tubercle bacillus. Abnormal test results indicating declining function of the transplanted organ are used to diagnose rejection. For the therapeutic management, it is important to monitor for evidence of potential transplant rejection. Also, immunosuppressive protocol is important to observe to prevent tissue rejection. And then it is also important to identify potential irritants that can cause contact dermatitis and of course avoid exposure. So the poison ivy, as mentioned in the previous slide, contains urushiol, which can be treated with corticosteroids, as of course ordered by the physician. For our nursing intervention, it is important to teach our client to avoid the offending irritant if a past exposure is experienced, and to apply topical and oral medications as ordered because this can alleviate many of the symptoms and increase client comfort. So, interpretation of skin test results is very important. You have to be familiar the use of grading system. So, a positive reaction is evidenced by an appearance of urticarial wheal. Usually, it appears red and there will be elevation. So the false positive results may occur because of improper preparation or administration of allergen solutions. So this figure shows an interpretation reactions, or this will be your reaction guide. A negative result, there will be wheal, which is very soft with minimal erythema. Positive one, the wheal present is between or from 5 to 8 millimeter with associated erythema. 2 positive if the wheal is between 7 to 10 millimeter with associated erythema, and 3 positive if the wheal is between 9 to 15 millimeter and slight or with slight pseudopodia possible with associated erythema, and 4 plus if the wheel is more than 12 millimeter with pseudopodia and diffuse erythema. So now let's discuss about allergic disorders, allergic rhinitis in particular. Allergic rhinitis is the most common form of respiratory allergy. This is also an example of your type 1 hypersensitivity reaction. If not treated, this may lead to complications such as asthma or even hearing loss and anosmia. The usual signs and symptoms include nasal itch, sneeze, anterior nasal secretions, and nasal blockage upon exposure to allergens. This is classified as intermittent or persistent. For diagnosis procedure, it is important to take the history of the patient and check or assess for the signs and symptoms. We can also perform allergy testing and skin prick. So this table shows the difference between the allergens and the triggers that can cause signs and symptoms of allergic rhinitis. We have the following allergens such as house dust mites, domestic and wild animals or insect venom, mold, perfume, feeders, food, and cleansing products. For the triggers, we have tobacco smoke, traffic pollution, air pollution, indoor or outdoor temperature, humidity, and stress. This all can trigger allergic rhinitis. The clinical manifestations includes watery nasal discharge or rhinorrhea, sneezing, nasal itching, and nasal blockage. For the management, it includes avoidance therapy, or every attempt is made to remove the allergens that act as precipitating factors. So you have to avoid those allergens. And the patient may be given antihistamines, which is used for mild allergic disorders. And we can also give nasal corticosteroids twice a day, oral corticosteroids, and immunotherapy, or known as desensitization to the allergens. So of course, for medication, there should be a doctor's order. So nursing management. So it is important for you to identify the allergen that causes allergic rhinitis to the patient. Symptomatic relief and evaluation of existing comorbidity. For example, if the patient has possibility of having asthma, and also nasal care. So now let's proceed to autoimmunity, rheumatic disorders such as your rheumatoid arthritis and your SLE or the systemic lupus erythematosus. So, autoimmune deficiency. This means where these disorders involve inappropriate reaction by the immune system in which the antibody form against self-antigen. Autoimmunity means a breakdown of tolerance in which the body's immune system begins to recognize self-antigens as foreign. So rheumatoid arthritis is a systemic autoimmune disease that causes chronic inflammation of the connective tissue, primarily in the joints. The joints most commonly affected area includes the fingers, the feet, the wrists, elbows, ankles, and knees. But the shoulder, hips, and cervical spine also may be involved, as well as the tissue of the lungs, heart, kidney, and skin. It develops most often in women. Despite intensive research, the cause of RA remains obscure. It is probably a combination of genetic, environmental, hormonal, and reproductive factors. So the following are the clinical manifestations of RA. So the patient may experience joint pain, swelling, and warmth. The joint pain are usually symmetric, or there could be erythema or redness or inflammation of the skin, loss of function or joint stiffness, especially in the morning, lasting for 30 minutes to 1 hour. Um, the hand and feet deformities happen caused by misalignment resulting from swelling, progressive joint destruction, or the subluxation that occurs with a bone slips over another. So this usually starts from the small joints. Then as the disease progresses, this may involve the large joints. The onset of the symptom is acute and usually bilateral and symmetric. So to continue with the clinical manifestations, the patient may have fever, weight loss, fatigue, edema, lymph node enlargement, and Raynaud's phenomenon, which is an intermittent attacks of the ischemia of the extremities of the body, especially the fingers, toes, ears, and nose, which is caused by exposure to cold or by emotional stimuli. So the attacks are characterized by severe blanching of the extremities, followed by cyanosis, then redness, usually accompanied by numbness, tingling, burning, and often pain. So the diagnostic examination of RA includes ESR, which usually reveals elevated C-reactive protein, usually positive in RA. ANA or anti-nuclear antibody, usually positive. Arthrocentesis by synovial fluid shows cloudy, milky, or dark yellow and contains numerous inflammatory cells, such as leukocytes and complement. The X-ray studies helps monitor the progress of the disease, which shows bony erosions and narrow joint spaces. The medical management includes the following. The patient may be given antimalarials or gold or penicillamine. Biologic response modifiers such as cytokines, NSAIDs, or COX-2 inhibitor, are corticosteroids, synovectomy, tenorrhaphy, arthrodesis, and arthroplasty, which are a surgical procedure. The goal is to achieve clinical remission and to relieve from joint pain and swelling. So another autoimmune disorder, we have systemic lupus erythematosus or SLE, which is a result of disturbed immune regulation that causes exaggerated production of autoantibodies. The increase in autoantibody production is thought to result from abnormal suppressor T cell function, leading to immune complex deposition and in tissue damage. It is seen more often in women, especially in the 20 to 40-year-old age group. So, systemic lupus erythematosus is a transient lupus-like syndrome that is indistinguishable both clinically and in the laboratory from spontaneously occurring SLE. Also can develop from prolonged use of drugs, particularly hydralazine, an antihypertensive agent, and prokinamide, and antidysrhythmic drugs. So there are 11 clinical findings of SLE. We have number 1, facial rash confined to the cheeks, ulmalar rash. 2, discoid rash, which is usually raised patches and scaling. Photosensitivity, or there is skin rash in sunlight. Number 4, oral or nasopharyngeal ulcers. Number 5, non-erosive arthritis or at least 2 peripheral joints. 6, serositis or pleurisy or pericarditis. So number 7, renal disorders. Usually, the patient may have proteinuria of more than 0.5 grams per day or cellular cast. 8, neurologic disorders such as seizures or psychosis. 9, hematologic disorders such as hemolytic anemia, leukopenia, and thrombocytopenia. Number 10, immunologic disorders. There could be positive LE cell preparation, anti-DNA, and false positive serologic test for syphilis. Number 11, there is a presence of anti-nuclear antibody or ANA. So there are 4 factors that affects the SLE or the predisposing factors, such as 1, genetic and hormonal factors. The onset is during the childbearing years. Number 2, environmental factors such as sunlight and thermal burns. Number 3, drugs such as use of hydralazine, apresoline in particular, prokinamide or your pronistil, INH, chlorpromazine, and other anticonvulsants. So the diagnostic test of SLE includes the following: LE cell test. This is to test for presence of lupus erythematosus. Number 2, ANA or anti-nuclear antibody test, which is the best definitive test for SLE since ANA is present in all cases of SLE, even in the inactive stage of the disease. Number 3, we can also have total serum complement, which is the best test to follow the course of disease. For the medical management, the doctor may order to give NSAID or non-steroidal anti-inflammatory drug. It is useful in treatment of the arthritis associated with SLE. Corticosteroid like prednisone ameliorates the mainstay therapy of SLE. Its side effect is to suppress immune system, thus suppressing body reactions to autoimmune antibodies. Number 3, cytotoxic agents. It arrests autoimmune activity of the SLE. Plasma paresis can also be given, or 3 to 4 liters are exchanged weekly from a plasma of a normal donor, which is used to remove circulating autoantibody and immune complexes from the blood before organ and tissue damage occurs. For the nursing care management, it is important to institute reverse isolation, encourage personal hygiene like oral care, bathing daily, and etc. Maintain clean environment, screen visitor from cold, avoid unnecessary blood transfusion, avoid fatigue, and discourage pregnancy. That ends our topic for this week, and this is the references of this presentation. Thank you, everyone. God bless.